Hello everyone, my name is Sarah Triplett, and my presentation is on smoking cessation during pregnancy. First, I would like to take a look at why we care about smoking in pregnancy. There have been many risk factors that have been determined in regards to smoking while pregnant that can cause harm to the unborn child. These include premature birth, birth defects, and infant death. Placenta insufficiency is one thing that I've noted during my research, and that is where the placenta is not working as it should, where less oxygen and nutrients are being sent to the infant. This can result in IUGR, which is intrauterine growth restrictions, also known as SGA, small gestational age, fetal stress, where the fetus's heart is not working properly, labor issues, where moms come in labor and have problems delivering the infant, and possible placental abruption, where the placenta adheres from the womb wall too soon, causing premature bleeding. Also noted is premature births, where infants are born too soon. This can result in heart and lung issues, blood sugar issues, and create longer hospital stays, as they most likely will be admitted to a NICU type setting. SIDS, which is sudden infant death syndrome, is also noted, and this is important for education, as moms need to be aware that during and after pregnancy this can be a concern. Finally, birth defects, and that is cleft palate, cleft lip, and those type of defects. Statistics in Kentucky are not great. We far exceed the nation in maternal smoking during pregnancy. The U.S. average ranges from 7 to 10%, where here in Kentucky we average between 19 to 26.5%. Kentucky.gov states the proportion of pregnant women who smoke in Kentucky is over twice that of a pregnant smoker in the nation. So what can be done? My PICO question in this class discusses an intervention based on smoking cessation support along with physical activity that can affect abstinence of smoking throughout pregnancy. First, Usher and colleagues in 2015 conducted a study with close to 800 pregnant women to participate in a 6-week session of intervention group following a treadmill activity, while the control group followed a behavioral support only. The study concluded that adding a physical activity intervention with a support therapy did not increase cessation rates at the end of pregnancy. This study, however, discussed several limitations, one of which was the accelerometer that they used was limited use because it had to be placed around the waist, and it was intolerable for most of the participants. Also, self-reporting data that when they came to the assessment time, they would inform the researcher of how much they had exercised each day and each week. This self-reporting could cause inconclusive or issues with the data. And also low attendance, where it was noted that only 50% of the control group had come to all the sessions, and only 29% overall of the intervention group came to all sessions. The second study, conducted by Prapavius and colleagues, noted a 30-participant sample in which they came to one study to determine the tobacco cravings and withdrawal symptoms would be decreased during, after, and at time intervals of that exercise intervention. So it looked to assess during, immediately after, and at 10, 20, and 30-minute intervals of the exercise. This data was collected by researchers to provide the most accurate findings. The effects of withdrawal and cravings were significantly lower post-exercise at 29% and after the exercise of 31%. Even though there was only 30 participants and only one exercise provided, these results point to a physical activity need to decrease the cravings and withdrawal symptoms, which will then increase smoking cessation in pregnancy. So looking at improving nursing care, we want to determine individualized care. We want to determine exactly where each patient feels, are they motivated, determining where they're at physically, emotionally, on how they feel regarding their care. Assessment to their barriers. This also talks in length about their physical, maybe financial, emotional support systems that are there that can create or that can create failure to succeed. We also want to determine what activities may be welcomed by the patient other than just one type of activity such as treadmill exercise. And then we always want to continue care throughout pregnancy, where we're assessing them at each prenatal visit, determining what is working, and provide education where it is needed. Then we want to look at the proposed intervention, where we'll want to provide educational tools to assist in increasing physical activity, assessing their withdrawal symptoms and cravings at each visit, and then offering classes to other members of the healthcare team to educate on all the options that could be available within the community and to reach more of our pregnant population within our community. Finally, getting started on this type of intervention, it would be important to address a local health department where we could hand out pamphlets on where to go to participate in these activities, resources for transportation, and then at the health department, continuing assessments to complete at the prenatal visits. A great place for physical activities would be like a YMCA, where students from universities that are studying maybe physical education could use clinical hours and teach this clientele and provide the activities for them. And then again, offering other options to them, such as maybe water aerobics or yoga. This concludes my presentation. I hope that you enjoyed it. If you have any questions, please send me an email at my EKU email. Thanks so much for watching.